What's up, guys? Today is July 16, 2024. I'm taking step two on July 20, less than 4 days to go. So the clock keeps ticking. The reason I'm making this video is because I finished reviewing the free 120 today. Um, and you can see that exam there. And what I want to do with the free 120 is that, as you can see on this Excel sheet here, I went over every single question, kind of made notes for myself, made a bunch of Anki cards as well. And on some of these questions, I made some comments to myself um, on why I missed the question. Like what stupid mistakes, what idiotic test taking mistakes did I make, which made me miss this question, and how can I not make those mistakes again? And so the purpose of this video will be just to go over some of the questions on this free 120 to reflect on stupid test taking mistakes that I made. And hopefully this will help me and anybody who's watching to not make these mistakes in the future. Um, but before I get started on the video, I just want to do a quick reflection of kind of where my mind is at right now. So right now it's 6:30 p.m. on a Tuesday. I took this exam on Saturday morning. So why the hell did it take me so long to review this exam? A few things. First of all, you know, you're reviewing the free 120. I haven't been reviewing it the same way as other exams in that this podcast guy, Divine Intervention, he's been making daily video, not daily, but he's made like 14 podcasts on this 8 hours worth of content, reviewing every single question. So I've been trying to listen to him while I've been reviewing the content. And so that's definitely taken me a lot longer. But other things which have really sucked time out of my day have been Anki. So Anki takes like 5 hours a day. Really, I'm doing like 1,000 cards a day, and it's like this is what I have on Anki. It's like I'm doing like 1,000 cards a day, and it takes maybe 2.5 hours. Um, and so but it still takes me like at least 5 hours, and so really I need to be more efficient with Anki. But the most important thing I have to do right now is fix my sleep schedule. And I know I've talked about that many times, but like even if you look at my exam here, you look at my incorrects, they're right on the left. I did okay. I mean, I didn't do as bad as too bad on the first two sections, but on this last section, these last 20 questions or so, 15 questions, just absolutely got destroyed and a bunch of idiotic, stupid mistakes. And so that's unacceptable. Like I can't be getting tired and careless on my third block when there's 8 blocks, of the test. So that's something I got to work on. And and there's a few things I have to do. First of all, I need to fix my schedule so it mimics test day. And then second of all, I need to start doing more untimed blocks on UWorld, um, and really get used to like having this kind of stamina to be able to do these questions because this is just stupid and idiotic. Like I cannot have this happen on test day. Um, so today I slept at 5 a.m., woke up at like 2, and I was telling myself, I'm going to wake up at 10 a.m., force myself to wake up at 10 a.m. so I can start to fix my sleep schedule right. But the alarm, rang on my phone. I hit snooze, woke up at 2, and I'm not even well rested, even with the fact that I slept an extra 4 hours, because it just feels weird. It's like just like I drove to campus today. I got to campus at 4. Everybody's leaving campus, right? And here I am. It's just everything just feels groggy and just so I can't be in this mood. Like I gotta fix my schedule. I gotta start waking up in the mornings. So it's Tuesday. I take my test on Saturday. So even I'm gonna even if I go to sleep at like 4 or 5, tomorrow morning, I'm gonna wake up at 10 a.m. And then slowly but surely I gotta wake up at 6 a.m. because and then even if I'm sleep deprived tomorrow, that's okay. but I don't want to be sleep deprived on test day. So that's my quick brief reflection before getting started on this review here. Okay, so I'm going to go over all the questions I made notes on. So let's look at here, question 12. Um, let's let me pull up the free 120 here. Obviously, there's spoilers. If you haven't taken the exam yet, then you shouldn't be watching this. Taking the free 120 yet. Okay, so let's go over question 12 really quick. 39-year-old guy comes to the office because of a 6-week history of mild fatigue and increased thirst and urination. During this time, he's had a 6 kilogram weight loss, otherwise asymptomatic, no history of serious illness, takes no medications. BMI is 19, temp is 37, pulse is 80, respirations are 18, blood pressure is 118/70. Lab studies show really high glucose, really high A1C. So we're going to recommend dietary modification. What else are we going to recommend? So what did I answer? Let me just remember the answer I made. Right. So I said um, metformin is what I said. Um, and the real answer is insulin, right? Because this guy obviously has, you know, for whatever reason, I thought this guy has type 2 diabetes. But this guy's type 1. I mean, 39 years old is pretty young. And then he's having all of these like classical symptoms of uncontrolled diabetes, like the polyuria, polydipsia. Somebody with type 2 diabetes would have metabolic syndrome. They wouldn't have weight loss. Um, and so I'm not sure why I missed this question. For whatever reason, I thought he had type 2 diabetes. Um, and so really it's just, I guess my tip here is just to focus and yeah, yeah, I don't think that this question here was as much a stupid test taking error as it was just I should have known this, and for whatever reason I didn't. Like I couldn't realize that it's type 1. Oh, the other thing I wanted to point out with this question was how do you treat type 2 diabetes? Yeah, you can treat it with metformin, but then all of these other drugs treat type 2 diabetes as well, right? But only one of these drugs treat type 1 diabetes, and that's insulin. And so whenever there's a bunch of answers that are kind of the same or they can kind of fall into the same category, then none of them are right. And so that's something else I wanted to point out with this question. Okay, let's look at the next question I missed. Okay, question 13. So 62-year-old man has severe shortness of breath 2 days after he was admitted to the hospital for management of an acute MI. He initially underwent cardiac catheterization with angioplasty of the left anterior descending artery and is currently being treated with heparin, metoprolol, and aspirin. Temp is 37.3, blood pressure is 78/50. Pulse oxygen room air shows an O2 sat of 87%. He's diaphoretic. Crackles are heard extending halfway up the lung fields. Um, trace peel edema. So 2 days after an MI, you start to hear crackles in the lungs. My immediate thought here was this is a ruptured papillary muscle. Okay, but what else? You know, and so my mistake here was overconfidence. This was one of the questions where I had overconfidence. Um, because I didn't consider the other answers. So let's look at the other answers. Acute dilation of the aortic root. I still don't understand what that's getting at because that would be like a coarctation, which like goes back into the and I have that explanations pulled up here. That would be like a coarctation, which goes back into the heart. So I don't think it's that because that would present differently. Yeah, it presents with severe chest pain and a wide mediastinum. But then this one, acute left ventricular failure. So if the left side of the heart is failing, where's the blood going to back up to? The lungs, right? And so with both papillary muscle rupture and left ventricular failure, you're going to have similar symptoms, like you're going to have crackles and stuff like that. And so this is one of those few questions where, um, normally the images they provide, stuff like that, it's all supplemental. if you don't understand it, I feel like the question itself tells you enough to answer the question. On this question here, um, the image should be helpful, right? I mean, the audio here should be helpful because in a papillary muscle rupture, you would have mitral regurgitation, whereas in left ventricular failure, you wouldn't. And so when you listen to this here, you don't have any evidence of mitral regurg. And so that's also something I should consider. Like, why are they even like making me listen to this guy? Um, and so yeah. So again, this one, the main thing to pull away from it, knowledge-wise, is that ruptured papillary muscle has a holosystolic murmur. I think it's holosystolic, isn't it? Mitral regurg, yeah, with the new holosystolic murmur, whereas um, left ventricular failure does not have that. So, okay, let's go next question. Okay, 19. So this one for sure, this one came down to a really dumb test taking error. So yeah, proceed. So before I discuss this question here, one thing I want to really quickly get out of the way, because I just remembered, is that almost all of the questions on the free 120, every single one of them, I had seen that concept before somewhere else. So, I have this issue where if I feel like I don't know the answer, I'll basically be like, I don't know what the fuck I'm looking at. I'll just answer something and keep, moving on, because the clock is ticking and I feel like I don't know enough. But at this point, I need to be confident in that whatever the answer is, like whatever the question is talking about something that I've seen before, no matter what. Because every single thing here, I've either seen it on a previous NBME exam, previous CMS forum, previous UWorld question. Yeah, so I've done 81% of UWorld, 83% of UWorld at this point. I've done all the CMS forms. So at this point, I can't be in this mindset where, oh, I don't know what the fuck is going on. I'm just going to answer something. Like that was an okay mindset to have at points during last year, when I was still in clinical rotations. But I can't be having that mindset right now. Okay, so now with that being said, let's go back to this question here. So this question, basically, you have this 57-year-old woman who um, who has a bunch of upper gastrointestinal tract bleeding. So like her stools are dark, like melena. I think it said that somewhere. So she's vomiting bright red blood. Um, and then I'm just skimming over. I won't read every single word here because I got this first part right. So the stool has alcohol blood, but it doesn't have like obvious blood. So the problem is in the upper GI tract. Um, Hematocrit is low, so obviously there's blood loss here, and I think PT there is normal. Just double check here. Um, PT is normal, which is understandable because the problem here is that you're losing blood, not that you're having bleeding disorders. And so, how do you evaluate blood loss from the upper GI tract? You do an endoscopy. So this first part of the question I got right. Okay, the second part is what threw me off. So I saw this picture here on the second part, and immediately, like I remember even like saying, while I was taking this exam, I was like, "What the fuck?" Like like the NBME, like, how much do you guys expect us to know? Like, am I supposed to be able to read freaking endoscopies now? You know, but I shouldn't be having that state of mind, right? The NBMEs are not going to ask us anything which we're not supposed to know at this level. And as inadequate as I might feel, within these last few weeks with my crappy test scores and stuff, all of that knowledge should be in here somewhere, right? So no, they're not actually asking me to like interpret what's going on here in this image here. Okay, what they want, the question here is, so we're going to give fluids and we're going to do NG tube lavage for this upper GI bleed, which makes sense because for any upper GI bleed, you want to do like 2 large bore IV catheters, you want to do a bunch of fluids and stuff. Um, and then this is the endoscopic findings. What do you want to do next? So my thought was like, okay, maybe because I have no idea what an endoscopy Like, even though I did a GI rotation last year, I still have no idea what I'm looking at. Okay. So I was like, okay, maybe this is like some kind of a mass, maybe it's cancer. So I think I probably must have answered like tyrosine kinase inhibitor. Oh, I probably answered biopsy. Let me just double check what I answered. Yeah, I answered biopsy because I was like, okay, this is cancer. We want to biopsy it. And I was thinking, okay, last year in rotations, I remember like seeing them biopsy stuff on endoscopies. But, you know, a few things. Okay. First of all, what category does this question fall under? Surgery. Whenever you have acute like GI problems, surgery. And on surgery, you always, number one step, if the patient is unstable, you want to stabilize them. So what's the question we're really asking is this guy is bleeding. What do you want to do next? All of this is just bullshit. It's just garbage that they want to distract us with. Guy's bleeding. What do you want to do next? And the answer is this: endoscopic hemostatic therapy. So I should have known the answer to this question without getting stuck on all this endoscopy, all this garbage. So the lesson here is like, if you don't know what's going on in the image, don't freak out, and don't start guessing random crap. Ask yourself, why are they asking the question? And make sure you understand the story of the question thread. Okay. So that's question 19. Let's see what else I got noted here. Okay. Question 23. All right. So this guy, he's a drug user, and then he was found unconscious in his home. And then his vitals are a bit off. He's hypothermic. His respirations are low. His blood pressure is low. And this probably has something to do with like the cocaine and the heroin that he uses, cyanotic and cold to touch at the left lower extremity. Um, I'm not sure exactly what's going on there, why that left lower extremity is cyanotic and cold to touch. And then you look at his labs. So potassium is 5.5. That's kind of high. HCO3 is kind of low, so that's some sort of acidosis. Creatinine is a bit high. Creatine kinase is super high. So immediately we know what this is, right? High CK, skeletal muscle breakdown in a guy who's been down for a while, rhabdomyolysis. So then I look at the answers. Acute kidney, like what's this patient at greatest risk for? Acute kidney injury, acute liver failure, cardiac arrhythmia, hypocalcemia, hypophosphatemia. So immediately, I see that high, because I'm just focused on these lab values. I see this like potassium is like above 5, which is above like I think what's technically normal. So let me just double check because I know on UWorld 5 is normal, but yeah, so 5. So then immediately I'm like, okay, hyperkalemia causes cardiac arrhythmia. Okay, but then what about this super high creatine kinase? Is that going to cause any issues? Yeah, so that's going to cause acute kidney injury. So that was the correct answer. And really, if it's 5.5, it's not high enough for it's going to cause arrhythmias. Um, and so here it's just like choose the better answer, I guess is what to take out of it. And yeah, and let me see if there's anything else that they noted in the answers here, which yeah, and then I think in rhabdo, I don't think you have hypocalcemia in rhabdo or hypophosphatemia. And so let's just really quickly go back over that because I think that's important to know. I have it saved in my hockey deck here, rhabdomyolysis. Yeah, see, I made an Anki card about it. And then, so this is the URL table about rhabdo. Um, you would see high potassium and phosphate, low calcium. So you'd actually see hypophosphatemia, good, high potassium, and hypocalcemia. Wait, no, you would see hyperphosphatemia. So in rhabdo, you see hyperphosphatemia. So that's also that just comes down to I didn't know about rhabdo well enough. Um, and then acute kidney injury is a complication of rhabdo. So okay. Um, what else? What else? What other questions do I want to go over here? Oh yeah, cat scratch disease. So quick note on question 32 here, which I managed to get right, but I still remember feeling kind of uncomfortable about. Okay. Question 32. Yeah, so here, the only point I want to make here is like the answer choices are Castleman, cat scratch, hidradenitis suppurativa, T-cell lymphoma, tuberculosis. And so by process of elimination, I was able to answer cat scratch because in the question stem here, this guy has like dogs, he has cats, he lives in a homeless shelter, decided like a bunch of like every single risk factor you can think of. But then you got to do process of elimination. One thing I want to point out is hidradenitis suppurativa. This thing here showed up on like a bunch of CMS forms and NBMEs and your world. So this is something that NBME, this disease here that NBME loves for whatever reason. I've never seen it in real life. But yeah, the non-fluctuant axillary lymph node should have that's what made me like rule that out. But the point I want to make here is I have no idea what the hell Castleman disease is. And like I said earlier, like at this point, the MME should be asking us about stuff we've seen, stuff we know about, you know, if I've been dedicated for so many weeks at this point, you know, I've done so much of your world, so much of MME forums. They're not they're not going to ask me about some random shit. So most often, if I don't like really know what's going on and one of the answer choices is random shit, what I need to do is like put that aside, you know, not answer that quite not answer that stem. Okay. Not answer that choice. Okay. So let's move on. Let's keep going. Yeah. Um, question 36. So question 36, 42-year-old woman comes to the office because of a 2-week history of sore throat and fullness in her neck. No history of serious illness, takes no medications. Vitals are fine. Oropharynx is clear. No exudates. Palpable fullness and tenderness of the anterior aspect of the neck. No lymphadenopathy. Lungs are clear to auscultation. Results of a complete blood count are within the reference ranges. Chest X-ray shows no abnormalities. Okay. And let's see what I had. Okay. And then actually, I just skimmed over the vitals, which was dumb. You know, you can't just do that. So actually, she has hypertension, and then she also appears anxious. Okay, so what can this be? Is this mono? No, right? Because mono usually would have exudates, so it's not that. And then mono would have lymphadenopathy of the posterior and lymph nodes. This guy doesn't have. This woman doesn't have lymphadenopathy. Is it GERD? No, that's it's just not that system. Is it laryngitis, subacute thyroiditis, or tracheitis? And so it says here there is palpable fullness and tenderness of the anterior aspect of the neck. And so I have like no idea what the hell that means. Like what is tender and full on the front of the neck, right? And so I answered laryngitis like an idiot because I was thinking like, okay, maybe like the larynx is full and that explains the sore throat. So I didn't think about the whole question here, right? Yeah, she has the sore throat and fullness in her neck, and it really what are they trying to get here with the palpable fullness and tender? Like so at the MME is kind of trying to trick us here, but kind of not, in that they're not spelling out what's obvious, which is that the thyroid gland is full. And I should have recognized that. And then really, I should have really thought about what every answer meant because I was kind of in a rush at this point because it was question 36. So maybe that's why I got it wrong. But look, if I had actually thought about it, thyroiditis, hyperthyroidism, you know, the hypertension, the anxiousness, that makes sense. Um, and then she was sick a while ago, right? 2-week history of sore throat, and so that typically happens after somebody's sick, and so that then I would have gotten it right. But here I just said, oh, it's laryngitis because of this palpable fullness in the front of the neck and the sore throat. So just I don't know, just I need to work on my logic there. Um, yeah, laryngitis would not even cause sore throat. It would cause hoarseness and voice change, and then tracheitis would have cough, high fever, and stridor. So I didn't answer tracheitis because of the I recognize that there would be a high fever in that case. Okay. All right. What else do I have? What more notes? Yeah, yeah. Okay. Question 4. So question 44 on block 2. All right. So here, this question, 84-year-old woman has a 1-month history of malaise, um, diabetes, She missed a bunch of appointments recently during the past 6 months with no explanations given. Um, her hemoglobin A1C 6 months ago was fine. She says she's been feeling fine. Her son moved back in 9 months ago. Husband died 5 years ago. Appears unkempt. She's alert and fully oriented. BMI is 29. Pulse is 80. Respirations are 18. Blood pressure is 160/94. So for whatever reason, like she's like decompensating here. Her blood pressure has gone back up. Her weight is up for some reason. Mucous membranes are dry, so she's dehydrated. Um, there's no memory deficit on mental status exam. Normal mood and flat affect. Fasting serum glucose is 380, and then yeah, so her diabetes is out of control too. And so I look at the answer choices here: dietary indiscretion, elder neglect, major depressive disorder, pancreatic malignancy, urinary tract infection. So, I think I got stuck on this question, but my thought process was, okay, this is like an atypical feature of depression. Like elderly people, when they get depressed, sometimes they might have atypical features of, I guess, sometimes they'll have like headaches and stuff, but I kind of extrapolated that knowledge to like, oh, the uncontrolled diabetes and stuff. Maybe that shows like that this person just doesn't care anymore. Maybe that's like anhedonia. But depression comes down to SIGI caps, right? And you need to have 5 out of 9. So does it say anything about her having sleep problems? No. Does it say anything obvious about her having loss of interest? No. Her affect is kind of flat, I guess. Um, is she guilty about anything? No. Does she have low energy? It doesn't spell it out for us. Concentration doesn't say anything about that. Appetite, so maybe increased appetite. Psychomotor symptoms, it doesn't say anything about that. Suicidality doesn't say anything about that. So does it meet 5 out of 9 SIGI CAPS criteria? No. And so if it doesn't meet the criteria, then it's not depression. So that's really the reason I wanted to point this question out. It's not depression if it doesn't meet the criteria. And so then you have to think what's really going on. And then this is a classic elder abuse question. Elder neglect is what they wrote down here. Because she suddenly decompensated when her son moved back in, so her son isn't like taking care of her. And so that's what this is. Dietary indiscretion. I'm not sure why that was wrong, but I didn't consider it. It wouldn't explain the unkempt appearance and the missed appointments. Yeah, and then here it says she has a flat affect, but no overt sadness, anhedonia, or depressive symptoms. So that's what I wanted to point out with that question. Question 6 here. Was it question 6? Yeah. Question 6 here on block 2. Okay. 41-year-old woman comes here because she was just discharged for acute pancreatitis. She's had 3 previous admissions for this problem, and then she's got a bunch of like problems. Like she doesn't have secure housing. She has alcohol use disorder. So then you go into this thing, and then it's like, how do you prevent future admissions? Abstinence from alcoholic beverages, enrollment in a health insurance plan, nutritional counseling, placement in a women's shelter. So I was like, oh, it's asking me about all these like social determinants of health. And, if this person doesn't have secure housing, then she's probably at increased risk. But I really should have asked myself, what's the point of this question? What are they trying to test me on? And it's not, the point of this question was pancreatitis. They're trying to get me to know what are the main causes of pancreatitis, which I do know. And I did know alcohol, gallstones, hypertriglyceridemia, medications. And so I should have just known, like, hey, she should stop drinking. But I overthought here. And so the takeaway here is ask yourself, why are they asking you this question? And they were asking me this question so I can have a better understanding of that, to test my understanding of pancreatitis, not to test my understanding of social determinants of health. Okay, let's keep going on here. Okay. So now let's go to question 19 and 20. Another one of these psych questions. And you can just tell from the way I just said it. I don't like reading all this stuff, but like that's just pure laziness, which is not okay. And so I need to work on that. Anyways, 21-year-old man comes to student health services because of a 6-month history of increasingly frequent episodes of moderate chest pain. First episode. So basically, these are a bunch. He's having a bunch of symptoms of panic attacks. Like he's getting like his rapid heartbeat, chest pain, sweating, nausea. And then the first episode occurred while he was sitting in traffic and feeling stressed. And then he had another episode um, 1 month later while on a date. Symptoms were so severe that he abruptly ended the date. And then during the past 3 weeks, he has experienced 2 to 3 episodes weekly. He says he fears having an episode while in public or on a date, so he has decreased his participation in social activities, and everything else is fine. So immediately as I was reading this question, I thought this is obvious. I'm going to get this. It's panic disorder. You treat it with SSRIs, right? But then I look at the answers and I'm like, God, I'm just like, damn it, like it's not where's panic disorder? And so I look at the answer to this agoraphobia. That's afraid of strangers. I was like, whatever, I don't know about that. Could this be anxiety disorder? Could this be illness anxiety? It's not illness anxiety because that would be like afraid of getting sick, which it doesn't mention. Social anxiety, somatic symptom disorder. And so really the problem here, let's see what I wrote down as a note to myself here. Yeah, the note I made to myself was read carefully, don't just guess stuff because you don't know. So agoraphobia is what? Fear of strangers. And so, if you read carefully, then it says like, okay, he fears having an episode while in public or on a date. So, so that's the answer, agoraphobia. Um, what I did here was I was like, okay, panic disorder is not here. And I had my own panic attack. And I was like, what is it? And I chose I don't even remember what I chose. I probably chose some garbage answer. I chose anxiety disorder because anxiety disorder can manifest in a bunch of weird ways. But yeah, just don't guess. So just like go back and read when you don't understand, which is also kind of hard to say because the clock is ticking, right? But it's got to be efficient. Um, question 20. Question 20. So quick note here. So this person has a episode of heavy vaginal bleeding, painless vaginal bleeding, 3 hours after sexual I mean, she's been having 3 hours of painless vaginal bleeding after sexual intercourse, and she's at 36 weeks gestation. So pregnant woman with painless bleeding is what? It's placenta previa. So I knew that. Um, and then she comes to the ER and let's see, heart monitoring showed a baseline of 155 with no accelerations or decelerations. Dynamometer showed contractions every 8 minutes. So I was like, this is placenta previa. She's at 36 weeks. Let's go ahead and do a C-section right now, which I got wrong. Because yeah, you treat placenta previa with C-section, but something was which Divine Intervention pointed out in his podcast was, do you know what's going on? Like, do you actually like really know what's going on here? No. And so if the patient is not hemodynamically unstable, something you should always do is first figure out what's going on and then fix it. And so because of that, the answer is not C-section, it's transabdominal ultrasonography. Okay. So 3 more questions that I want to talk about here. 3 more dumb mistakes. Um, okay, question 31. One sec. I think I've missed one here. Yeah, 3 more. Question 8. Let's go back to question 8 really quick. Okay, this is one of these types of questions. So my daughter's eyes and legs have been swollen. Um, blah, 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 blah. The patient seems super swollen, has like acute like edema, right? And then, yeah, just edema all over the body. And then the urinalysis showed some RBCs, a bunch of protein. Um, yeah. And so which lab finding would you expect to be decreased? And so hemoglobin doesn't say anything about blood loss, so no. Albumin, maybe, right? Because he's having a bunch of edema. When albumin goes down in the bloodstream, that brings down the oncotic pressure. When oncotic pressure goes down, that means the that pushes fluid out of the bloodstream. So that makes sense. But then also C3 and C4. I mean, is it possible that this bloody urine, and then she was sick 2 weeks ago? Is it possible that she has PSGN, post-epicardial glomerulonephritis? Maybe. Triglycerides and urine nitrogen, no. So here, basically, two answers are correct, could be correct. And so whenever it comes down to two answers being correct at the same time, and then this is something that divine intervention pointed out, choose the one that is always correct no matter what. And so like, do I know 100% that she has PSGN? No. And also, does PSGN, post-streptococcal glomerulonephritis, cause anasarca? Does it cause the widespread edema and stuff? No. And so albumin is the correct answer here. Okay. Okay. Um, and then one more I want to go over, and then two more I'll just talk about. So here, this patient has a myelomeningocele, 1 week old newborn, and then it asks me what is an associated finding of this myelomeningocele. So here again, this question, I I got into this mindset of like, I should have studied this somewhere. I should somehow magically know like everything that's associated with the myelomeningocele. That's not what that question is asking. This is a question that's just asking for logic, right? This person has a problem in their spine. What's going to be associated with that problem in the spine? And the answer is neurogenic bladder, right? Because if part of the spinal cord is compressed, then you're going to have like bladder problems. But I answered cognitive impairment just because I was, being stupid and like randomly guessing stuff because I felt like I didn't know. Um, so yeah, for some reason, folate rings a bell right now because doesn't folate, what causes myelomeningocele? So maybe deficiency of something, right? Let me just see what the explanation was. What is this? What question is this? 111. While folate deficiency is a risk factor for neural tube defects, it is not a direct consequence. Okay, fair enough. So folate deficiency causes spina bifida or myelomeningocele or whatever, but it's not a consequence of it. Okay, good to know. All right, and then two more questions I just want to point out. I can just talk about them. I don't have to show them here. So for question 34, the note I made was read the question, idiot. It literally says the monospot test is negative. So here, this guy had a bunch of like symptoms of mononucleosis, but the monospot test was negative, and he had low white blood cell counts, and so I answered mono. Um, this was just me being stupid. I mean, it says in the question some monospot test is negative, but what it comes down to is this was like the last block, and so I was tired, which I should not be tired, and I was rushing. And so this is just, be more efficient with time and then make sure you read the questions. Should be obvious. You know, Anybody in freaking middle school should know that, but for some reason I still struggle with that problem. So there's that. And then this question here had like all the makings of an insulinoma with this person who like keeps getting dizzy and then feels better after eating. But um the problem here was I ignored the lab values. Like if somebody has symptoms of insulinoma, then their C peptide should be super high because they're making a crap load of insulin, but their C peptide here was low. So I should have known from that, okay, obviously this is not insulinoma and CT scan will be normal. So just a few stupid mistakes there. So, anyways, that's just a quick review of, you know, dumb mistakes I made and mistakes I should not be making on test day. So, hopefully that'll help me and it'll help you guys as well. So, all right, a few more days to go until test day. Uh, Wish me luck and good luck to all of you as well. And all right, thank you.